So thanks for reaching out. So let me just talk about us, and then what we're doing, I guess, and then maybe some questions will derive from there. So we got till what time, generally?
We're here as long as you're here.
Oh, geez. Well, I have to go home and help the daughter pack the U-Haul trailer to move Chicago, but I got a little while. Yeah, it's exciting times, I think, in the field of, there's numerous symptoms that are associated with KLS, but one of them, I mean, we just heard an eloquent description of the behavioral manifestations that are one part of this, but one thing that's clearly very characteristic are like these long periods of sleep. I mean, hypersomnia on a long temporal domain, right? Weeks or many days, and sleep of 20 to 21 hours, sort of disconnect that from those other issues, those frontal lobe, those disinhibition, the other hyperphagia, the other things that can happen and are associated typically with the classical definition of the disorder. And so our interest is really in the whole thing, right? We want to make it go away. It's not helpful to try to lead a very productive life, certainly, if you have these unanticipated and unexpected episodes of that are seemingly out of control. So we want to understand that and help. We see probably there's several people in the room we think that we've seen or evaluated and are in, I think, a larger database.
I'm just going to plug students on my vacation.
I was liking the bear thing there. I guess that's the hibernation part.
Just turn down the mic on the meeting board. Just disconnect.
There you go.
Does that work?
Yeah.
So I think we've been motivated by my clinical impression after seeing a lot of patients. I mean, remember, I think importantly, and I'll just tell you about some of my theoretical beliefs, is that diseases that are defined by people and physicians are really signs and symptoms. They're clusters, right? We have a sign of a disorder that you see, and then there's symptoms of the disorder that are perceived by a patient. And physicians do their best job to say, oh, well, this cluster of signs and symptoms we're going to call A, and this group of signs and symptoms we're going to call B, because it's distinct. There still may be some overlap in a Venn diagram sort of thing, that one of the symptoms may be shared, but usually when physicians do this, they're all well-meaning. We have to start somewhere, right? But we usually don't have a clue as to what causes it. So biologically speaking, we don't really know if there's justification or verification until we have to start somewhere, right? But those things evolve. So those things are iterative, what we would say iterate, with increased knowledge. Can we learn about the biology? So that's, I think, important to learn as we're going through this, right? I mean, we see it in other sleep disorders evolving, because sleep, as a major symptom, is still really, it hasn't been around for very long. The field of sleep medicine has really only been around for 20 years or so. I mean, maybe 30 or 40, but I mean, as a distinct academic interest and specialty, not very long compared to, say, epilepsy or, other aspects. I mean, neurology has only been around since the 60s. 1960s, the first academic neurology department in the United States was in the 1960s. a lot of us were, I was born before them. and whoever wants to put their hand up, so, it hasn't been a long time. Just remember, yeah, there's urgency, but just, it's important to know where we come from, right? And when we're still at a very young age in all of this, and things are going to move forward. So, one of the things that we're interested is in sort of seeing if some of that hypersomnia that's experienced by patients with Kleine-Levin may have something to do with our recently discovered issues related to hypersomnia that we see in what people call idiopathic hypersomnia. I guess it's not idiopathic anymore. We can talk about it. Narcolepsy without cataplexy, right? We now know with 5 recent papers that entity is more like idiopathic hypersomnia. So that's an example that says, geez, maybe these names don't make a difference and we should just focus on the commonalities and things and try to figure out if we can get at that somehow. So that's certainly our bias, right? It's one way to look at it. There's other ways to look at it. And so we see a lot of patients. There's several that we've seen that we've analyzed spinal fluid, and it seems to be that in those cases, they do look like patients with KLS, that look like patients with idiopathic hypersomnia in terms of what their spinal fluid looks like. And then also you've seen some of the recent reports in the literature, I'm sure, anecdotal, of course, about use of different medications based on that knowledge, including clarithromycin and a little bit of fumazanil, that suggests that maybe, possibly, we're not sure, may have some potential benefits in breaking, a spell, quote unquote, of Kleine-Levin, or maybe delaying a spell of Kleine-Levin. We don't know yet, right? I mean, I agree. It's anecdotal, but for a disease where there's no FDA-approved treatment and it's rare, anything should be looked at, carefully, but certainly investigated. So those are exciting things. Well, we just got funded for an NIH grant to sort of replicate our findings in idiopathic hypersomnia, that there is some natural endogenous substance that interacts with the GABAergic system in the brain to cause the sleepiness and hypersomnia. Whether it contributes to the other symptoms is a whole other issue of KLS. And to do that, we're going to look at patients, hopefully, either in between acute sort of spells, quote unquote, or hopefully during the spell, although we realize that from our experience and from the past, as well as what we've just heard, may be prohibitive in patients that are really disinhibited and potentially combative, and we certainly don't want to do that to hurt them. So my issue about communicating is we'd like to get them usually, from my experience of talking to patients, is that these spells do not come on like bolts of lightning. They usually kind of come on over hours to maybe even days. So getting people to communicate with us and be seen very early on in the spell, so we can assess them then, as opposed to the spell, might be a very way to get across that practical problem or hurdle that I think we've had in the past with some people in the room, in fact. So that's one issue. The other one I want to say is something that we're sort of noticing in not only treating people with idiopathic hypersomnia / type 2 narcolepsy / whatever we want to call it, is independent analyses that have looked at some of the treatment responses in these patients when they're getting either, and in this instance, fumazanil through the vein. And these are people that have no interest or knowledge of patients. They don't even know what an EEG is. right? So these are mathematicians looking at data. They don't care about much. They love data, which is great for us. But they looked at it and how patients responded to flumazenil. What was interesting is that they pulled out a couple patterns that may be relevant to this, and that is that there's patients, and we see this in our clinic, not for KLS, I'll say, but the patients that are very sensitive to the medication dose, they'll kind of like riding a wave when they're getting their flumazenil, okay? And they're very sensitive to what we can measure in the plasma from flumazenil. Interestingly enough, there's an equal number of patients who, once you dose them with flumazenil, they get better and better and better and better as the day goes on, totally independent of the blood level of flumazenil. It's as if you started a perpetual motion machine. You just kick-started, you just nailed it hard, and it said, it's like Newton's law, the object in motion stays in motion. Scientists have called this phenomenon hysteresis. Once a object or state gets in a certain steady state, it prefers to stay in that state and prefers mathematically to be in that state versus changing to another state. So that's kind of interesting, right? Because you think about KLS and we've tried to treat it, right? And if we're given large doses of certain drugs right at the beginning of the spell, it doesn't, it's very, very difficult. So we're really, I get the sense from both of those experiences and observations is that it's going to be really intently upon us is to, I think, maybe to understand that phenomenon, and then and I think the treatment implication is get something on board very, very early. And that was the sense I think we communicated in that letter in response to the single patient when we reported 5 patients with erythromycin is if you get it on board temporarily, quickly, at fairly high doses, you may be able to sort of push that, that metronome the other direction, okay, and keep it from switching, right? You've heard Cliff Saper talks about the sleep-wake switch, right? And if you kind of envision, maybe that's what's going on, is that switch, once it switches, you're stuck, right? So you want to stop it before it gets there, right? The only other issue I've seen related to KLS that I find of extensive interest that I think has really got to be studied, and I think Isabel Barnoff has started, she's still here, she'll go back.
She's already left.
She's gone? That's too bad. So Isabel showed in her imaging study, I don't know if she talked about that, right, is this presumption that patients in between spells are normal, and you see different changes in brain activity in between spells. So when there's no evidence and people walk around and say things like, well, normal in between, that may be not the case. The absence of evidence is not evidence of absence. And if you ignore the negative data that you think is negative, that can be very problematic in terms of really getting to the bottom of the issues, right? So we've seen a lot of stuff. I'll tell you just an anecdote of a patient, not someone here, but was sent to us or came to us with Kleine-Levin, possibly referred to sources here. Sounded like a fairly typical story, and there wasn't this sort of tremendous behavioral abnormalities around the episodes, the disinhibition. I mean, there was some of it, but I think manageable, I guess, from listening to the story. But what was kind of clear was that it was precipitated by many of the same things I think you've heard, right? Alcohol, sleep deprivation, some of the stressors, psychosocial stressors that may be associated with a quote trigger of a spell. And he had learned not to do these. This is a young man, I think a sophomore in college now. And so it was, oh, I've modified mid-behavior, and in between spells, I'm fine. I go to class, I stay awake, I succeed. He was in a very good school. So after break, after Christmas break, I said, will you sleep all you want on your Christmas break? And we just had finals. So we'll test you after you had all the cookies and Christmas stuff and you're all rested up. So we put him in the laboratory and he slept 11 and a half hours. He was not in a spell. He slept 11 and a half hours, and then we did a nap test. He fell asleep in 3 minutes on average. So what disorder are we going to call that? He has these spells. Yeah, right, you're going to call it narcolepsy. Yeah, right, he sleeps too much. Right? That's you just document it. It's a finding. It's objective. You can say that that's one thing for sure. But he didn't want to be treated. He didn't think there was a problem. Still going to school, had good grades, slept a lot. See you later. You know, don't do. So I still don't know what he has, but I'm just sort of saying with the testing procedures we have. You know, what are we going to have fights about? Well, what we're going to call that? I mean, the data's the data, right? And he sleeps too much. And is it a problem? I don't know. Don't tell us. I guess if he has a spell, we'll see him again. But clearly, he's pretty sleepy. I mean, not many of us in this room will sleep 11 hours. Except young man in row 2 here. Yeah. So, yeah.
I have a question. The clarithromycin, you sort of hinted that if it was taken at a relatively high dose during the prodromal phase, so when you feel an episode coming on, that it might thwart the episode.
Right.
So can that be taken orally, or is it something to get the high dose? Okay.
So it's an oral drug. It's a common antibiotic. It's called Vioxin. It's generic. It's still kind of expensive, even though it's generic. There's no clinical trials. So I gotta give the disclaimer, right? There's no double-blind placebo-controlled trials on it. For that, there is a recently published double-blind placebo-controlled trial on idiopathic hypersomnia and type 2 narcolepsy that was just published in Annals of Neurology. Now, whether that translates to anything else, I don't know. We don't have a trial. But yeah, it's oral. It's fairly safe. It's been used chronically in HIV patients for, you know, kind of atypical infections that they're prone to for like 5 years, daily dose.
Because that sounds like something that a person could go to their pediatrician or their, you know, pediatric neurologist and probably get a prescription without too much pushback, because there's no big downside to it.
Well, it's interesting you say that, because theoretically that's the case. We live in a litigious society, and I think is part of the issue, and we thought the same thing for idiopathic hypersomnia, but there's physicians that just aren't comfortable prescribing medicines for things medicines that they're not familiar with. It didn't help that a Dutch group decided, or a Danish group decided to show off how well they could, their software analyses could pull records from the Danish population and say that sudden death was associated with this drug in like 1 in 5 million cases or something. And it got published, and then we were, oh my gosh, you know. It wasn't really anything pointed at clarithromycin. I guess it's just commonly used in Denmark. And they wanted to show us how well smart they were to make software that cull all their socialized medicine data. So that hurt a little.
So how could a parent go about securing that drug to have it on hand? So if they want to try it, you pretty much have to have it on hand for when the episode's
well, that's sort of another issue, right? You have to have it there and available. So, you know, just, I don't know how to do that other than Ask your physician and pretend you have bronchitis or something. I mean, no, right, I'm not advocating that. I don't know how you get it. I mean, I guess you could legal, you can take the 2 papers that are published and show them that for sure. I mean, that's a good thing. I mean, but some people don't read and still are uncomfortable, right? It's not a double-blind controlled trial, so I don't know how what can I say? Yeah, just for people, clarithromycin's in the same family as Z-Pak. And about how many people have had a Z-Pak prescribed by their physician? Okay, bingo. So not something that anybody should get in a big, you wouldn't think a big concern about, but Z-Pak is azithromycin. So if somebody says, well, azithromycin will work, we don't know, right? It's just because it's the same class doesn't mean it's going to work. And we know, at least in our experiments we've done in a little dish, it doesn't seem to. It's unique to clarithromycin. So Z-Pak, which is azithromycin, not clarithromycin, may be different. What's interesting from a mechanistic standpoint of these medications is that they are all potent anti-inflammatories, the macrolide antibiotics. So things like cytokines, I don't know if you've heard of them, people have looked in KLS patients for this, and I think some other patients. Cytokines get released by the body when it's inflamed or infected. Separately, if you isolate these and put them in animals, the animals get sleepy. So the reason, quote unquote, that we get sleepy when we're sick is because these cytokines are floating around. And people, naturally would say, well, geez, I mean, maybe those are mediating sleepiness and all sorts of things. And that's been looked at, I think, a little bit in narcolepsy. It's certainly been, I think, looked at maybe in Kleine-Levin, maybe not. So these drugs actually knock down the production of those. So those are, it's sort of like almost you have 2 mechanisms, that maybe luck is the second one. I don't know why they work. Right. Another question. Get on another topic. I have to
by large dose, you mean grams and grams?
Sorry?
By large dose, you mean like a gram?
Yeah, gram. Yep. So the dose for an adult is 500 milligrams, and we usually give it breakfast and lunch. You have to take it with food. It's as Dr. Trotty was talking about yesterday in her trial, our trial. It has a lot of gastrointestinal side effects, so it's important to take it with food. Something. And maybe water with a little lemon juice because it tastes like you're sucking on quarters. I've tried it. It does taste like you're sucking on quarters. Other questions? If anybody's local here and interested in being seen, I'd be more than happy to see them. We do in this grant sort of have some support to study patients, in and out of spells. If the communication lines are kept, and we can get you in. We do have ways to do that.
Okay, I have another question.
Sure.
How can a patient go about getting flumazenol if they haven't already tried it?
Okay. So I don't know how many people was anybody here for the Hypersomnia thing? So quite a few. Okay. So flumazenol at the moment is there's some access problems with flumazenol. And if you get on the Hypersomnia Facebook groups or whatever, you'll see that's being communicated. The only place until recently that it can get compounded by someone who is comfortable doing it and has access is here in Atlanta. That pharmacy is Pavilion Pharmacy. And they're in the process of trying to get other, they have, I think, 3 different sources of flumazenil that they're trying to get in right now. What I had communicated at the close of yesterday's session was, why did that happen? Did we want everybody off for some surreptitious, malicious, masochistic reason? No. It's taking off. I showed a slide that 2 of us have been prescribing it as of last April, and as of December 2014, 23 physicians in the USA were writing prescriptions, sending them here to the pavilion and having them filled. So we don't know what they're prescribing it for. Have no clue. I presume it's for hypersomnia of some sort. And we realize it's a compounding pharmacy, so they and they have to purchase it and expect that there's a customer. So, you know, that's a business decision. They can't anticipate who's going to start prescribing it. It's obviously prescribed off-label because there's no indication, and we have no idea of the long-term safety of that drug. It was approved for intravenous use as a single dose. So we don't know if you give it long-term what the implications are. We check liver functions if people stay on it chronically, we check their liver functions, we check a blood count every few months just to make sure, because there's no data. When the FDA has drugs approved, they have data relevant to how the drug's going to be dosed. In this case, single use, they know 50 times 2 milligrams is tolerated. That's 100 milligrams of flumazenil, like you could treat many large elephants at the Atlanta Zoo with them. It doesn't hurt, it doesn't do anything to people, but that's a single dose. We don't know repeated. We personally have not seen anything in about 170 people over a few years. Take that for what it's worth. There's a couple long-term exposure studies in the literature in rats and mice. The mice live longer and the rats are smarter on maze testing when they get older. So if we're the same as rats and mice, maybe flumazenil should be in the water supply. I don't know.
Thank you.
What is your opinion regarding the importance of vitamin D and KLS?
I can't answer that question because I'm not aware of any data about it. I checked vitamin Ds in lots of patients. Vitamin D, if you associate it with any disease right now, will get you an article in the Journal of the American Medical Association, it seems to me. Just a lot of people into vitamin D in Parkinson's disease, vitamin D in chronic fatigue, vitamin D in, it's low in so many people that it's easy to statistically to say it's associated with anything that's also common or uncommon. Actually, uncommon, probably even better. It's not going to hurt, right? I mean, people have shown that very high levels of vitamin D are not toxic, right? You can take pretty significant levels of it. So, I mean, given that you don't have a treatment, you know, there's certain things that may be not unreasonable. I mean, 2,000 to 5,000 units is, you know, they're recommending now, I think the daily intake for women is 2,000 international units, right, a day. Not for KLS patients, just for adult women. And then 1,000 for men, I think, and African Americans might even be higher, right? Because it's made in the skin. You need sun exposure. If you have dark skin and don't have sun exposure, much more of an issue if you person of color.
Any other question? Yes, my son's 17 years old, and he's on that medication.
On which medication?
On the terrorism medication.
Okay.
And his episodes last 11 days, and when he takes the medication, it's gone from 11 days to the first time, which was 5 days, and after that, it's 11 days, goes down to 9 days. And right now, he's in a mild state, we're on 6 days, but it's not, this episode is not as bad as the regular episode. He's still with us,
Yep.
but he's not as bad as if he was in an episode.
Right, so there you go. and other anecdote. So, but let me tell you the problem with clarithromycin. So we use it a lot, not just in KLS. So we have a lot of experience with it. Clarithromycin is a very large molecule. There's a thing called the blood-brain barrier that large molecules don't like to jump over. So this is why I have patients come in from all over the country. Some doctors are kind enough to put them on 500 milligrams twice a day. It doesn't do anything. They fly all the way here. I said, you better try it a couple days to double that. And they're like, poof. So I think that may have to do with access into the spinal fluid. We've looked at a few patients, like 3 patients who are off and then on clarithromycin, and you don't see a lot of it in the spinal fluid. It doesn't get in, and it seems different for everybody, how easily it gets in. So my initial response is, that's great. It probably argues in favor of either some mechanism of clarithromycin if it's really true. But gosh, we need to either find another medicine that gets in the brain easier or go to other doses, which I'm not recommending because I'm not sure what dose you're talking about, but because there are side effects, you know, there's this cardiac thing and higher dose may be bad, and we don't know that. So that's an interesting observation, and we hear a lot of that, you know, that if you get it early, that's what we wrote in that letter, I think. You know, there's 5 patients in that letter that we wrote to the editor about the one patient. We didn't have as much space. It's just a letter.
Last question.
Yes. Hello.
Yeah.
I took a lot of medicine during the journey of this disease. The medicine is Ritalin. Methylphenidate, Ritalin.
Oh, methylphenidate?
Ritalin?
Yeah.
Ritalin. I take this medicine. Doctor advised me to take this medicine. He can control for the hypersomnia. He helped me a little bit, but after that, he made me very angry, very aggressive sometimes, and because of that, I take it off. And he told me also they have a new medicine here, I think, but the name of this medicine is modafinil.
Modafinil?
Yes, modafinil.
Okay.
Yeah, he told me also he's good for hypersomnia, but unfortunately this medicine is unavailable in German and is very, very expensive.
It's hugely expensive.
Yes. Just I want to ask, is this medicine, modafinil, is really good for hypersomnia control?
Well,
effective?
Kleine-Levin or hypersomnia?
Thank you.
Hypersomnia is really, so the question was, he was prescribed methylphenidate, just to repeat it, what I think I heard, methylphenidate, which is Ritalin, to help with hypersomnia, either I guess in or outside of an episode of Kleine-Levin. Was it inside of an episode of Kleine-Levin or just always sleepy?
Yeah, he was taking it
persistently.
Yeah.
So, right, so this is the big difference that I see in these different approaches when you're sort of talking about thinking of this problem as a construct, is that as a neurologist and other people in the field, when the brain goes bad, you usually think that there's a function that you lose. And then the natural response is to fix the function that's missing by getting a replacement therapy. So in this instance, the natural tendency is for people to think, well, if you're sleeping too much, then your wakeful brain is broken. So I need to give you medicines that increase wakefulness. That's what Ritalin does. That's what modafinil does. Okay? They do it slightly differently. And nobody's done a trial. There's 2 trials that are published now for hypersomnia that modafinil does work in a double-blind, placebo-controlled fashion. Not for Ritalin that I'm aware of. There's only 3 published trials. 2 for modafinil, 1 for clarithromycin for hypersomnia, not related to Kleine-Levin. But what we're doing in general is thinking in our group that these disorders are not manifestations of a problem staying awake. That this is a problem that should be viewed as too much sleep, that the sleep system is overactive. So the analogy to think about that we've used in talking to the media and trying to get it to, is that if you're trying to drive a car and you're pushing the gas pedal, that's gasoline, that's modafinil, that's trying to stay awake, it's Ritalin, it's Adderall, it's dexedrine, this is pushing the gas pedal. But the problem in this disorder is not that the gas pedal is dysfunctional. The problem is somebody left the parking brake on. Okay? So you can push the gas pedal as hard as you want, and you're moving, but you're going, instead of going 80 or 90, you're going 20. That's what it feels like when, to a lot of patients, when they're getting these medicines to try to keep them awake, when the sleep system wants to sleep. The other analogy we use, and hopefully it's helpful, is all the guys, or I guess the frat parties or the sorority parties, right? You had a little too much to drink at 2 in the morning, and somebody says, you can drive home. Here, have a couple cappuccinos. Well, you're not awake, right? You're not functional enough to drive that car, but somehow you're awake enough, right? Because you got this thing to keep you awake, but the real pull is you still have this sleepy thing that's there, the alcohol. Okay? That's the other analogy. So the brain's not functioning, the body's not functioning normally in that system, but what you're fighting is the parking brake or this pull for the sleep system to be on. So we should be spending our attention thinking about what that mechanism is and how do we take the parking brake off. Might as well, right? I mean, how many years have we just been pushing the gas pedal? Does anybody here have a solution? I did it too, because that's all I was trained to do. It doesn't mean it was right. It just means it was the default that what was available. I did it. We did it for 10 years. I mean, why did you say, well, why didn't you guys discover this stuff earlier? Because we did the same stuff. And then we realized it doesn't work.
The doctor told me in Jordan that I problem is in the hypothalamus.
Yeah.
The hypothalamus.
Yeah, the hypothalamus is this really small part of the brain, deep in the brain, where it modulates a lot of these automatic behaviors, right, including feeding. And that's why people sort of say, well, Kleine-Levin is maybe something to do with the hypothalamus, because all these functions live near one another. This control and this coordination of eating, the coordination with staying awake or being asleep, with body homeostasis, things that we just kind of take for granted, right? They're automatic, it's the autonomic system, and we don't really think about it too much, right? Because it's not a stroke. And we just kind of, and then when it goes wrong, yeah, it wreaks majorly havoc, right? When the transmission on your car goes, it's trouble, right? It's not just the turn signal, it's not just the windshield wipers, it's something major structurally wrong with, maybe structurally wrong with the innards, right? That really control, some of the things we take for granted. Yes, ma'am?
Is it the lack of blood flow to the brain in the hypothalamus? So maybe
maybe ask for Virginia on that?
I have no clue that there's evidence that that's the case, but I mean, anything's possible, right? I mean, I don't know what the blood flow looks like to the hypothalamus. I mean, sure, right? I mean, we take brain images to make sure that there aren't either structural brain bricks and mortar, or, you know, the flow of blood to it to make sure that it's okay. Those are certainly maybe more rare. I would call secondary causes of hypersomnia, but they're probably not accounting for the, you know, the larger group of what's, you know, out there walking around. You know, we see some rare cases of narcolepsy that are like that, for example, where it's a structural problem, right? What we're talking about is a humoral problem, I guess, right? There's a humor, for lack of a better, you know, I hate to talk about Aristotle and humor, but, you know, that's, you know, structural, humoral difference. Other questions, or?
Thank you very much.
All right.
I think we're gonna